So I'm going to start off with what I call a softball question. It's my favorite question because the range of answers I've ever received every time I ask this question is just wild. So we had our regular session and a special session in 2017. And, we got some stuff done on maternal mortality. So my first question, and this is for everybody, we go down the line. How would you grade how the legislature did on maternal mortality? And we're averaging together the regular session and the special session. Starting with you, Sherry.
Well, how did they do? What's the scale?
We're doing A through F. We can even do
Oh,
an
I
A,
see.
B schedule if you want.
I really don't know.
Okay.
So I'm going to take an incomplete.
I would actually say that they're somewhere between C to C minus
Okay.
at this point. Some positive things were done as far as covering some funding, but there is major problem we have that would contribute to the maternal mortality and morbidity. We still have major problems with access of care, major problem with Medicaid expansion, major problem with availability of Medicaid for pregnant women after delivery. Another major problem with the undocumented population. We have a lot of problems that we have to access. Unfortunately, all these problems require money, and I think the legislature has a long way to go.
Okay. Representative?
Okay, this is I'll give a disclaimer. I'm a member of that legislature. But for those who don't know, in the regular session, a lot of legislation was pushed to advance maternal mortality and morbidity, to extend the task force, the life of the task force. I was one of the big proponents. Unfortunately, right before the end of session, this started around Mother's Day, a lot of bills were killed in the Texas House, mine in particular. It was called the Texas Moms Matter Act. The bill wasn't targeted, but all the bills were taken down on the calendar by a group of members that were very unhappy with the overall status of what was going on in the House. So they used a procedural move to take down all of the bills that initially had already passed committee and should have passed. So those bills died. I was able to bring mine back as an amendment to another bill. And then once again, we were almost in the end zone, and the bill died again in conference committee because there was another civil war going on between the House and the Senate. So on that level, Marissa, to your first question, I would have to give us an F on the regular session because we didn't get anything done. And then, right when I thought that we were going to have a special session, I was sitting in my office lonely and dejected because all this had happened, and I decided to write a letter to Governor Abbott to ask him if he would add this to the call if we were going to have a special session, and that means put this legislation on the agenda. He has the right to determine what he wants us to address during the special session. And he agreed. He did it. And so there were 20 items. It was number 20, but we got in, okay? We got in. And we were able to extend the lifespan of the maternal mortality task force, which was huge. And we made some meaningful changes in the statute, new rules. We gave better direction for what they should be studying, recommendations to look at the disparities for African American women. We gave direction for better death certificate reporting, which I know we're probably going to get into. We asked them to look at best practices around the country for the states that are getting it right. So we were able to do that. Now, to Dr. Zaid's point, there's still a lot more to do. So I would give us, coming from where we started, an F, and then I would give us a B minus, I guess, because there was still more we could have added in the special session. And so then to average out, I guess we're in the C minus range. So we're still needing to move the ball down the field. But I am very proud that it was a bipartisan issue. I mean, we surrounded each other with that, and we actually were able to get that signed in. Because if we hadn't have done that, we would really be bad off.
Mm-hmm. So we have an incomplete, we have a C minus, a C minus-ish. Okay.
Usually an F and an A makes a C minus, but I don't know what the average is going to be. If we're going to grade on a curve.
We'll grade on a curve. It's fine.
Okay,
it's fine.
let's grade it on a
It's all
curve
good.
and continue.
Well, so good to know. So you, Representative Theory, you kind of touched on this a little bit, but for people who maybe don't always follow the legislative session, So for people here, for people watching on the live stream, kind of talk to us about the vibe, the tone in the Capitol when you were on the House floor about maternal mortality. Was the will there? What were some of the challenges? I mean, you kind of touched on them, but walk us through, what were you hearing from your members on the floor about this issue?
It was just like anything else in the very beginning. There was a lot of confusion. Members didn't even really know what it was, what we were talking about. They would hear us say this, me and a couple other colleagues, Representative Wiley and some others, saying maternal mortality and morbidity. And they're like, what's going on with that? So it wasn't the sexiest bill in the session at the time. We were dealing with so much school finance and other issues having to do with mental health. And so in the beginning, there really wasn't much will. And so it's just like anytime you have a cause, you've got to raise awareness. So we really started talking about it a lot. And I started doing outreach to advocacy groups and asking for their support. And then the media, I think you all and other outlets that really started covering the issue. And so my office even started getting calls from national newspapers, international. The BBC came down and watched me lay out the bill in the House. So that started to shift, Marissa. Mm-hmm. Then all of a sudden, members said, well, am I for this? Or is it a Democrat thing? Or Republicans? Are we supposed to be voting for this? Am I supposed to not like it because you're a Democrat? And so I started talking one-on-one to members. And I said, if you're pro-life, you're for this because this is saving moms' lives. These are women that chose to bear life. And I kept saying this over and over, that in Texas, we don't want, or anywhere, a woman that chooses to bear a life to have to do so in exchange for her own. And that started to resonate. And so then the will was there. And then once the governor put it on the special session call, it was pretty much ordained. And then everyone said, well, there's 19 things on here we're supposed to fight about. Is this the one that we can all hold hands on and say we agree? And then we did.
Okay, all right. For other two panelists, what goes through your mind as providers in your own communities when you hear that some legislators didn't even know this was happening? Sherry?
Well, it makes me think that perhaps they were focused on their own issues and not really paying attention to what was happening. I did hear about the Medicaid expansion work and know that didn't pass, but and that does have implications for mental health because that would be a way that people would continue to access care after they've delivered.
Well, it makes me kind of sad, actually. And I think it's a two-way street. It's not only the representatives, but also providers in general, healthcare professionals, whether it's physicians and their patients, need to do a much better job in communications to their local representatives as far as what the problems are. Obviously, this is a much bigger problem than we thought. And it's really sad that in this day and age, we rank this low across the nation, and compared to Canada and Germany, it's almost like if you don't want to die when you get pregnant, you need to move out of the country, move out of Texas, which is insane. As much as we know now, this should never have been the case. The other thing that makes me sad is the fact that when legislatures start deciding whether he likes it or not because it's a Democrat issue or a Republican issue, as opposed to it's a patient issue, as opposed to it's a human issue, these patients are dying unnecessarily. But by the same token, the state is taking major steps, if you will, to avoid that and to improve that. Come to mind the introduction of the AIM bundles. There's a lot of things that the states is trying to do, not only through the task force, but also through the TMA, also through the American College of Obstetrician and Gynecology and the Texas College, or the Texas chapter of that. And everybody is trying to improve the health of women, keep them alive, but also to reduce morbidity, which is a bigger factor. For every, just like Dr. Hollier said at one point, for every 50 patient that dies, there's 2,500 in the same year that had a major complication, not just a simple complication. It's a much bigger problem. And if we don't put our hand on the pulse and know exactly what's going on and how to improve it, it's only going to get worse. We can't ignore it. And funding is a major, major issue in this, and that's where the legislation comes in. And that's why they have to be informed. This money is saving lives. They're there to protect us. Yes, roads are important. Education is important. But what good are they if people are dying when they get pregnant?
Well, I'll open it up to the panel again. So is Texas spending the right amount of money, making the right types of investments in women's health right now?
Well, I'll take that one first, and I'll say that's an easy one, no. You know, as excited as I was that we were able to get the legislation passed, it was passed with no additional funding for the task force. So they were to use what we call, it's a little catch-all phrase, use existing resources. So now they're doing all this research and scouring through all these death certificates and birth certificates and doing all these studies with very little money. And to your point about Medicaid expansion, so, you know, we didn't accomplish that. So without additional dollars, in the end, we're not going to be as successful. So absolutely, next time around, we hope to have more funding.
An easy answer. The answer is no.
No. Okay. Okay.
No.
Okay. So that y'all can agree on. All right. Well, you know, thinking about something that happened a couple weeks ago, there was a study that came out by some of our top state health experts that basically said that in 2012, we overcounted the number of women who died, who were considered maternal deaths. So instead of 147 women dying, it actually was 56, thanks to a methodology they're using to confirm maternal deaths. I mean, when everyone here saw that study, I mean, what was going through your mind, and how do you think this is going to impact how Texas moves forward? Sherry?
I'm not sure how Texas is going to move forward, but whether it was 56 or 146 doesn't really matter to me. It really highlights the issue. I agree that education is probably the most important factor in terms of getting the constituents to speak to the representatives. We need to have, you know, the medical community actively engaged with the legislature and make sure that our voices are heard.
Doctor?
Okay, so I just looked at the exact numbers before I came, just wrote it down to make sure I'm not, you know, I don't quote them incorrectly, if you will. And I'm just going to give you the numbers and let you guys make your own mind whether this is still a problem or not. So from 2000 to 2010, the reported number was 17.7 death per 100,000. That study that came in with an elevated number was 38.4 per 100,000, which of course was extremely alarming, and that's what caused the legislation to do a lot of, start the task force and among other things. In 2016, these numbers were corrected because of reporting issues that they reported, and came down to 14.6 to 18.6 per 100,000. Still too high. The national average is not that much better, it's 15.9 per 100,000. But in comparison to that, Germany is 7 per 100,000, Canada is 8 per 100,000. We're still extremely high. Now, you have to remember these numbers kind of screwed a little bit because African American women have a much higher risk than anybody else. Women above age 35 are even higher than that. And just to let you know, despite that, compared to other states, Caucasian women in the state of Texas have a rate of 13.6 per 100,000. In the state of California, is 6.2 per 100,000. So if you're a white woman getting pregnant in Texas, maybe you should move to California so you won't die. That's really the message. African American, 27.8 per 100,000. Above age 35, 32.2.
So that's a lot of people who are dying from this, is what you're saying.
Yes.
Okay.
So there's a lot of things, simple stuff, low-hanging fruit, if you will, that we could do to reduce that number. And that's what the state is doing, and they have to be commended for that. Again, the registration started the process, the task force started it, pushed the Department of Health and Human Services to do it, and finally now we're starting the AIM bundle program, which I'm extremely hopeful that it will reduce this number significantly.
So when the report came out a couple weeks ago, I started getting some calls from different reporters from everywhere, and they wanted to leap on this and say, oh, wait a minute, you guys are fine. I just read the report. It's lower than what we thought. So was the whole thing a mistake, and did you all waste your time? And I was like, wait, pump the brakes, hold up, let me explain. So to everyone listening, that was for 1 year for 2012. And what we're looking at only in that report was women that died from the moment they had their baby up to 42 days. So that's the World Health Organization definition of a maternal mortality. The Center for Disease Control goes up to 1 year. So the moment you go to the 43rd day, the doctor will tell you up to the 1 year, it went back up to the 150 women in Texas. So we still have an issue. We still are confronted, like in my county, Harris County, we have some of the highest rates of maternal mortality. They're right in my zip code in my district, which was shocking because I didn't even know that was going on, and yet I was championing the legislation. And so Harris County is still pushing forward. So my goal remains the same, to continue working. And remember, that was 2012. We don't have data going forward. The task force is so underfunded and their resources are so limited. That's just where they are right now. So we're in 2018. So if we were to pause and say there was no issue and stop working, imagine where we would be down the line when we go back and look at the numbers going forward. And so there's still so much work to be done. We've got to find out. And what they said was, and this was an educated guess, is that the reason they think it was flawed is it was basically the click of a mouse. There's a drop-down box when a woman dies, and it will say pregnant at the time of death, when you drag the mouse down, it'll say not pregnant. They're just guessing that someone clicked pregnant when they were trying to click not pregnant. That's what we think happened. So if that is true, then we'll have to change the way that software looks if it's going to be subject to that level of human error. So I feel like it just underscores the need for more attention to be paid to women's health. If our lives and, even in death, we're not even being given the quality control that we need. If you're telling us you just click down on a mouse and that simple click could change whether or not you died from a embolism being pregnant, or whether or not you had a stroke, or whether you were pregnant at all, then we need a better system for that too. So a lot's being exposed, and I'm sure Dr. Zeke agrees with that.
Great. Well, I want to kind of pivot just a little bit. We talk so much in Texas about the importance of access to care. We talk about, there's all these women falling through the cracks, and I feel like sometimes I write that in a story or someone says that in a speech, and everyone's just kind of like, okay, who are these women? So I would just love for everyone here to kind of talk about who are the people in Texas most at risk when it comes to falling through the gaps on access to health care.
Well, I would definitely start with the uninsured. I would start with also rural counties. And also, in my case, I work in mental health, and so there is a lot of stigma around coming forward and also identifying symptoms as a mental health condition rather than just a coping problem.
Well, this actually is a much bigger problem. Of course, the uninsured and socially disadvantaged are major issues, but even patients who are able to get on Medicaid during their pregnancies, they lose their Medicaid 60 days after delivery. And we've done a lot of work in order to be able to allow those patients to automatically enroll into the Women's Health Program as opposed to reapply like it used to be. Still, it's a big problem for access because most of these women don't know that they're already eligible for the services, and most of these women are too busy to take care of their children or go back to the workforce. A lot of these women don't even show up for postpartum care. So 40% of all women that live in the state of Texas don't go back for postpartum care. Postpartum care is extremely important because that's your transition between being pregnant and going back to your well woman. That's the time that you're at higher risk for maternal morbidity and mortality. That's the time that you have to figure out what you're going to do for your family planning needs. That's the time to know are you going to be able to use birth control or not. You have high blood pressure, diabetes. What kind of health time risk that you're carrying just given the disease that you have during pregnancy. So pregnancy is considered like a natural stress test where we can tell now for sure that patients who have preterm labor or have diabetes or hypertension has a long lifetime risk for increased cardiovascular disease. Well, these women don't know that, and these women are not being screened down the road for that, and these women are not doing their lifestyle changes to avoid that, and that's not going to happen unless they have access. So access also equates to funding. So you have to bring in funding, you have to communicate to these patients, you have to be able, if we at least can extend Medicaid a year post-delivery, that would save the state a lot of money on the long term in case of morbidity and mortality. Now, these patients, you know, there's certain studies just been done for African American and Hispanic women where just giving the patient education in the hospital before they leave and give them a phone call 2 weeks later has been shown to reduce the incidence of postpartum depression and increase the length of breastfeeding. These things are not that expensive to do. But they require a change in culture, require that everybody understand that we're having a problem and we need to fix this problem. So access to care is extremely important. It's probably the most important thing that we can do to improve the health of our citizens, whether it's by Medicaid expansion or at least extending Medicaid for a year for these patients in order to be. And then once you do that, patients need the education as well. Providers need the education as well, whether it's healthcare physician, nurse midwives, primary care physicians, nurse practitioners, everybody needs to understand that they can still provide for these patients and bring them in.
Great.
I think we have a lot of work to do. So the ball right now rests with her.
Again?
Only
And her
you,
group.
Representative Theory, only you.
So everything they just said, uninsured, women on Medicaid, all these issues, but take that and then amplify it, multiply it, and then add in African American women. So, and the reason I say this is not that they're necessarily on Medicaid, it's the issue of the disparities in the treatment. That is the real elephant in the room, people. That is going to be, it should be a big takeaway from today. It's a conversation that we're having very much in Harris County. I'm on a Reducing Maternal Mortality and Morbidity Steering Committee. It consists of over 80 different leaders from hospital systems, our county, our city, our state, and we're no longer debating it. The physicians that work with us are not debating that. It's implicit bias in everywhere else in life. Unfortunately, it's happening in maternal care. And so the disparities in the treatment for African American women are also leading to very poor outcomes. And so that's the most at-risk group. I thought when I first read the report, the 2016 biennial report from the task force, and I was shocked, stunned when I found out that African American women were dying at 3 times the rate of other women. And, you know, I had a baby 5 years ago and I was over 35. So I knew I would be at risk because I was over 35. I always say I had no idea that just by virtue of being African American that I was more likely to die than anyone else. And I vacillate between, I wish I had known that information. Then I think, no, I'm glad I didn't know it. I might have been under so much stress just thinking that. But my own experience, you know, I had health care. And doctor, would you believe even after that, we maybe can get into it later, but even after my very bad birthing experience, I had a C-section. I never went back and saw my OBGYN. I haven't even said that until today. I was never given a call. Nobody checked on me, nothing. And I have health care, and I'm the educated woman. Nobody checked to see if I had developed an infection from my cesarean. I didn't know. I was so confused in here. I'd never had a baby before. I didn't even know if the stitches were supposed to dissolve. Was I supposed to go back? And I was so focused on taking care of my daughter. And I'd had such a bad experience that I really was wanting to put it out of my mind. And I was kind of embarrassed that the whole thing happened that way, even though it wasn't my fault. And so as a woman, I just kept saying, well, let me just focus on my daughter. And I never went back.
I mean,
Can I actually
yeah,
interject
go
on
ahead,
that?
yeah.
That's very interesting you said that because, as I mentioned before, 40% of women don't even go back for postpartum care. And it doesn't make a difference if you have insurance or not. Look here, right there. But you have insurance, you have well.
I didn't even know, though. Nobody called. They just rolled me. Nobody said to come back. And you think I would have known? I kind of thought I was supposed to come at some
Well,
point.
it's both ways because really and truly, that's the whole idea behind the ACOG new committee opinion, and that is You know, we're trying now to turn postpartum care into what we call the fourth trimester, because it's an ongoing process. It's not just one visit. You have to get in touch with the patient within 2 to 3 weeks. If that's for the low-risk patients, not the patients who have high blood pressure or at risk for a stroke or whatever the case may be. And you need to educate those patients and what's going on. And it's not only the physician, but it also involves family members. It also involves the pediatrician, primary care physician, a case worker, coordinator. It's lactating consultant. It takes a village to raise a child. It takes a village to take care of a woman just had a baby. It's not just one man's job, and it's not only her job. The whole thing starts during pregnancy. You know, physicians, providers have to actually talk to the patients during pregnancy about how they're going to manage their postpartum care. It's not, okay, you delivered, I'll see you in 2 weeks, oh, you're doing great, we'll see you later, no big deal. It doesn't work like that anymore. And we understand that this is actually part of the problem. We're too busy. We're concentrating on point of care, fee for service. You see the patient today, you don't see that many patients, you're not going to make a living. It doesn't work like that anymore. We have to change our focus to patient care, that our job is to take care of our patients. Just like the patient job is to take care of themselves, yes, but they need the education that we can only provide. The patient has to participate, yes, but the provider also has to start the process and have to arrange for it. In our office, we just started a process where we're having a postpartum care plan for every patient. And it's a blanket plan, but it's individualized for every patient that comes through. This patient will need this patient will need that. And it's based on that opinion that just came out. Again, I go back and say, it's not a single problem that if we fix everything will go fine. No, it's a lot of different causes. But there's a lot of low-hanging fruit that we can at least pick real quick and move on.
Sherry?
I was just going to add that it is a cultural shift that we even conceptualize how the mother is doing after delivery. And for, generations, we've had just a focus on, did you have a healthy baby? Then you're good. And there's not an expectation that you will be looked after or you should be concerned about yourself. And so there's a whole cultural shift that needs to happen. And that's one of the reasons I was so excited about the ACOG change of just standard of care, because it's the fourth trimester is something we talk about in mental health, maternal mental health, all the time, because there's not a focus on how the mother is doing. It's just, is the baby okay?
So for those who maybe don't know and are watching and maybe don't know, so the American College of Obstetricians and Gynecologists earlier this week released a revised opinion saying that instead of women coming in at 6 weeks postpartum, so after having their babies, they should come in at least no later than 3 weeks. So they cut the time in half, which is a very big deal for them as an organization to do that. And on top of that, they talked a little bit about that fourth trimester of care, where instead of it being just you go for that one appointment and you're done, it's not just a single encounter, it's an ongoing process. So that's what we're kind of discussing right now. I kind of want to talk to the providers about this. The representative just talked about how, she was just taking care of her baby and was really focused on that. But there are women who maybe are not as educated, who maybe are even lower income, who maybe didn't have that same level of support that Representative Theory had. So, what are your challenges as providers when you're trying to talk to women about the importance of postpartum care if they're dealing with these other social determinants of health? So let's say housing, domestic violence. How do you help them navigate that?
Well, there's not one answer to that. In our case, we try to offer free services. We try to offer weekend and evening appointments. We try to make it, we're about to roll out a teletherapy program where we can see people online. You can certainly do talk therapy counseling online, and this will give access to care for people outside of the Houston area. So it's about listening to what the needs are, and there are so many pressures around getting back to work and taking care of other responsibilities, that cultural shift that hasn't happened yet, that, I need to think about how I'm doing, and if I'm suffering, that I should do something about that, rather than just power through or ignore it, or, you know, turn to some other unhealthy coping strategies, like, you know, maybe, I don't know, drinking too much to manage your stress, you know? I mean, there are things that we can teach in terms of good self-care that will make a huge difference in a mother's mental health.
I totally agree. To answer your question, we're not doing enough. And the problem is not only the legislation, it's not only the funding, but also as providers, we are, as physicians and nurse midwives and PCPs and all that, we're busy taking care of day-to-day patients, and we will have so many different problems, and we tend to lose track of the individual patient and their issues. And we have to do a better job, and I'm hoping that this plan that we have, having somebody dedicated to call the patient back, trying to figure out what's going on and trying to fix it, will make a difference. Domestic abuse is a big problem. Opioid is an epidemic, as we all know. There's a lot of different things. At the end of the day, when you are basically making minimum wage of that, and when the statistics say that, you know, most women go back to work 10 days after delivery. 10 days after delivery. Who can go back to work 10 days after surgery or get delivery and take care of the baby and do that? So you have to put yourself also in that patient's shoes, if you will. Are you really worried about yourself, or are you worried about your 2 or 3 kids and making a living and taking care of your abusive husband and doing this, that, and the other? The last thing on your mind is your own health. So that becomes the problem of the whole, you know, community, of the society, if you will. We have to get involved. We have to educate our patients. Again, the education doesn't start after delivery. It's too late. It's too busy with the baby. Education starts in the first trimester, first time you see her. And then again, second trimester, third trimester, talk about the postpartum care. How are you going to do it? You need to take care of yourself. You need to get some rest. Postpartum blues, postpartum depression. There's a lot of different things that has to be done. Now, if we address all that, it's great, but still we have to have some sort of way to fix it once we find it. So we still have to go, we're always going to go back to access to care. We're always going to go back to funding, if you will. There's still going to be a problem, because my fear is, all right, we're not digging, so we can't find these problems, but now we're going to start digging, we find it, and then what are we going to do once we find it? We have to be prepared for that. Just an example, I can tell you how many times I have a patient with cancer, and I can't find an oncologist to take care of that patient because of their, and they have insurance, and they have, whether it's a managed care Medicaid, whether it's Medicare, or, I mean, it's supposed to be a way of funding. It doesn't mean it equates to access of care. So we go back to postpartum care, and it's to find somebody who have a major domestic abuse problem or opioid issue, and I can't get them into mental health because whether it's funding or even with the funding, we have a major shortage in providers. So how are we going to fix all these things? Now we're going to start digging, finding the problems, and then feeling sorry for the patient. It's not going to cut it. Mm-hmm. So it's a comprehensive plan that we have to start, and I'm extremely happy with the AIM bundles that the state is trying to implement, because it's not only about fixing the problem. It's basically about being prepared for the problem. It's also about finding early signs of the problem and trying to prevent it, and then about actually dealing with the problem. And the most important part of it is it's a reporting mechanism that we can learn from what we've done so far and measure our success in fixing this problem. And if we can implement that in most of the hospitals or all the hospitals in the state of Texas, that will take us to the next level. Again, these are the immediate things for mortality. Morbidity is a much bigger problem, and it requires access and requires an army of people to be able to figure it out and fix it. Again, I go back, the ball goes back, to say right here, and the registration. They have to find the funding. And their job is not easy, because we're competing with a lot of different things, and we're competing with Harvey, again, local for Houston. That's going to take up a lot of money for the next session, as far as the funding is concerned, as the budget is concerned. But we have to figure this out, because we can't let our women die and have major problems.
One of the other points we have to think about too, we look at the shift and we say, well, are the women knowing to call the doctor? To your point, this is something that people haven't really been addressing. We have a shortage of OBGYNs right now. So even if you took the initiative to call, and even if you had health care insurance, there are times where a woman can call right now and she can't even get in within that prescribed time. They may say, well, our next appointment, let's see, it's the end of April, our next appointment is in June. And yet you're having a violent headache every day, you're feeling weaker, you may not know you're this close to having a stroke or having a heart attack. And let's say this is 43 days out and you've been calling, you called on the 16th day, but then you got busy back with your life and you've been taking Tylenol and you're just thinking that you're tired because you're a new mom. And then something happens to you on the 45th day. And it was actually a direct result of an underlying disease that you had while you were pregnant and while you were released. That wouldn't be counted as maternal mortality. And so even if the woman right now were to be responsible and do her best to try to get in, we don't have enough doctors to see the women. And so I am really a big proponent of telemedicine now in this area. And so for people that don't know, last session, we finally were able to get Texas to approve telemedicine. That was been a big thing going on in Texas. We were dead last. And so now they're still working out all the payments, but health insurance companies now can be reimbursed in doctors' offices. They're setting up they're getting all the software and being able to treat patients right then and there. And it's actually approved for while you're at home. And Medicaid now is approved for it. So I believe going down the line, this is going to be a game changer. If a woman can just click in and ask that question and give her symptoms and be able to talk to a doctor or an OBGYN right afterwards, that's going to be huge than having to, you talk about transportation. If you're packing up a 5-week-old and you don't have a car, and then you're thinking, okay, I got to put the baby with me, I got to get strolled, I got to get to the doctor, and they told me this, and then you catch the bus and it's raining and this, it's easy for people to just say, I can't get there. So I think telemedicine, and I'm going to be pushing some legislation next session to look into, to have them study more of where these pockets are. We know they're in rural communities. Rural communities are very similar, though, to urban communities where there's an underserved community. So if you look at impoverished areas in urban communities, they have the same problems that rural communities have. They just don't have access. Sometimes there's no hospitals. I just read something the other day that said that 1.8 million people in Texas, if you add up all the counties, don't live within 100 miles of an OBGYN. I was like, what?
Well, that brings me to, and also really fast, we have 5 minutes until the question and answer portion, so start thinking of your questions. It's going to be great. We've touched on this a little bit now. So we talked about we have a shortage of OBGYNs, we have a shortage of doctors, I think we have a shortage of nurses, psychiatrists, counselors. I don't want to go on because it's starting to sound sad. But how do we get more healthcare providers of all types to come to Texas, not only come to Texas, but to serve in these underserved areas, rural and urban areas?
Other states are providing incentives. Yeah, I've been looking at other models. I do know that there are other states that are providing incentives. There's supposed to be some federal legislation and grants that are going to come down to try to incentivize people to go in. I was looking specifically for obstetricians and gynecologists to try to incentivize them. Right now, University of Houston is going to have a medical school, and one of the big proponents of that is that they want to encourage students to go into general practice medicine and be able to serve right in the communities, local communities. Apparently, again, this all has to do with the cost of healthcare. A lot of the graduates are going into very highly specialized fields, and that's what's leaving the dearth of physicians. So I think that, again, it's just creating awareness and a need at the medical school level and incentivizing them. And that the way our healthcare system, the model, the business model it's based on, it's so for-profit driven, and these doctors are forced to have to see so many patients in a day so they can even earn a living and get paid. It's going to continue to be like an assembly line. So I think eventually, if we can change our model of healthcare in this country, all of that can change. But I know the doctor should know.
Well, right now, we're having a big problem with graduate medical education, because we're increasing multiple medical schools, but there is no place for these medical students to get trained. And once you spend $100,000 on a medical student until he's done, or she's done, and then she ends up going out of state for training, most of them don't come back. So we really need to increase the funding for graduate medical education in the state of Texas. We have already a major influx of physicians to the state, thanks to tort reform. A lot of physicians would rather practice here than other places where they cannot even practice proper medicine for fear of being sued unnecessarily. So that's helping a lot, but that's not enough. When you have that many medical schools here, and then the Texan medical graduate cannot get into residency in the state of Texas, you have a problem. Now, if you want to go, that's a different story. But I'm talking about the ones that want to stay and can't because there's not room for them. So, again, the TMA has been advocating a lot for increased funding for graduate medical education, and it increases here and there. But it seems like more money is going to medical schools now than going to actual residency programs. And we need residency programs to train those medical students before we waste the money that we spend on them. It's not, to me, it's not really wasted because somebody in the United States is benefiting out of it. But again, it's this Texas money that's going somewhere else.
Mm-hmm. If there was a graduate program that focused on maternal mental health, there would be an increase in providers. When I started this over 20 years ago, I went to the library and checked out books. There was nothing in my graduate school training about maternal mental health. And there's a few pockets around the country and the world that are addressing it in a more academic way. But if there was a training program that was actually focused on this particular issue, we probably would have more providers with actual knowledge and expertise in this area.
Great. I believe we can start the question answer portion. So just a quick note before we do that. We're looking for questions, not comments, not speeches, not campaign speeches. You laugh, you see everything during Q&A. So we really want to make sure it's a quick question so that we can get to as many people as possible. So you're the first hand I see, so speak loudly.
Can you guys all speak to the importance for collaborative care between providers? I think that especially in perinatal mental health, it's important that, not that everyone's adequately trained, that's actually very important, but it's also important that there's communication about the client or patient between the different providers. Can you guys speak to that a little bit?
Yeah, I mean, it's if there is universal screening for postpartum depression, which is the #1 complication of pregnancy, then there should be an easy referral source for doctors to utilize, that they have a place to send these moms. This is the problem with getting any traction on universal screening, is that, the physicians are asking, where do we send them if they screen positive? So, there needs to be collaboration on all levels way before the mother is screening positive for postpartum depression.
I totally agree. Now, as you know, that screening is required by law. So everybody now does screening. How they do screening is a different story.
Right.
And what they do with the positive screen is a third story. It's nothing more frustrating than to have somebody that you know is at risk for something as bad as this, and your hand tied, you don't know what to do with them. You can't treat them yourself, you're not trained to treat them, but you can't find out who somebody who was treated or is trained to treat them is available to take care of them. And that's regardless of the funding, because you could have the best insurance there is. If there's not somebody to take care of you, nobody can take care of you. Mm-hmm. So collaboration is extremely important, but again, it requires increase the number of providers. It requires maybe training some sort of mid-level providers, if you will, somebody in between that can actually deliver the care and then leave the specialized to certain people. And there's a lot of things that can be done. Again, it's a pyramid of needs, if you will. So we have people dying. We need to take care of that. We have people with major complications. We need to take care of that. Postpartum depression comes under that part of major complications. Goes back to access of care, goes back to funding. So we can try as much as we can find the problem, and we have to be able to take care of this problem. And currently our hands are tied for multiple reasons. And this is one of the good places to discuss these problems that we have and try to find a solution for it. Solution is not only money. Money is important, but that's not enough. There's ways to invite more people to the state, whether it's providers. There's ways to involve the community. There's ways to change the culture, just like mentioned before. It's no different than putting a seatbelt in your car or quit smoking. It's not easy to do. But now it's become given because we were able to change the culture. That's not going to happen unless we find some sort of a driving force that has enough money and interest to be able to do this. Right now, the people that have the interest take the money. And it's not easy to change culture. But it's also a science. There's no reason to reinvent the wheel. There is ways, and the government knows, and insurance companies know it, and physicians know it. They just have to come together and decide, okay, it's not about the money, it's about the patient. It's about the citizens of the state. That's my 2 cents. It's very frustrating, I have to tell you. But I'm very hopeful, like I said, with the AIM bundle, that at least we're going to start on the right track.
And that's what I was going to say in Harris County. That's part of the bundle, what we're doing right now. I had a meeting yesterday with our steering committee, and they said there are hospitals right now that already are getting started in adopting this. And so when the patients are discharged, they're going to be providing them information on how to find a physician for postpartum follow-up. But again, it's not uniform just yet, but we're hoping that these protocols and these toolkits and best practices will be, at some point, followed down the line from all the different hospitals and will become common practice. So I know you want to get to another question.
Great. Oh, okay, you're the first hand I saw.
Okay. This is a question for Dr. Z. Dr. Z, you've been in the area now for 20 plus years, and it seemed like the whole issue, 20 years ago, it didn't seem like we were having an issue with maternal mortality, or at least it wasn't put before us. Has something changed in the last 20 years, or is our data just better? What is your experience based on your last 20 years?
Oh, I just want to repeat the question for those on the live stream. I forgot to do that the first time. I apologize. The question is, repeat your question, though.
Sure. What's changed?
What's changed?
For 20 years, are we just reporting the data better, or has something really changed to make our maternal mortality outcomes worse now than they were 20 years ago?
So the question is, what's changed in the last 20 years or so?
Well, okay, the major thing change was awareness. The problem has been there. We just weren't aware of it. That's one thing. Second, of course, is the reporting mechanism and the fact that now we realize that it's a problem. Before that, people were still dying. You wouldn't see that many people dying in a small hospital with a small number of deliveries. But when you get across the state and look at everybody, yes, as you know, we discussed earlier today, the rate was 17.7 until between 2000 and 2016. Well, right now, there is about the same. It's not that much different, given the correction that we came in. There was a change in data reporting. That's why there was a major increase.
The problem's there. We're just shining better. We shine the light on it.
Well, now we're aware of it, and we're trying to shine light to make sure that everybody is aware of it as well, is what it is.
And our population's larger, to Dr. Z's point. They're seeing more women, more hospitals are delivering more babies per month. The state is growing. And so that's something that we're trying to get also in Harris County. It's just a central data bank. We don't even have numbers from where they're not sharing the data between hospital and hospital as to how many deliveries they're having per day, per month, per year, how many C-sections they're performing. You know, California took the lead on that and was able to get all that information and even reduce the number of cesareans they were doing. But we have to start with the information. And so, you know, a lot of it's just guesswork. But we know women are having babies later in life. The population is growing. The hospitals are having more output. So all those factors will make a difference.
It goes back again to the AIM bundle. And this is why it's so important coming in. It's not only because of how to fix the problem, but how to report it, learn from it, and measure progress. Now, 10 years from now, we should be able to sit down and say, all right, our rate is better. We don't have as many people, as many patients dying from hypertensive disease or from DVT or from postpartum hemorrhage. These are the preventable death that we have. These are things that we ought to be able to prevent. And then we can measure it 5 years from now, 10 years from now. Are we doing the right thing, or what we do is not working? And needs to focus on something else. Opioid. This is the second set of bundles coming out. It was women with opioid dependency. This is a huge problem. So again, I'm very hopeful with the AIM bundles.
Great. Ma'am in the back. Yes, in purple. I think you're in purple, yes. Mm-hmm. So I just want to make sure I understand your question. So are you saying, are we going to essentially add, like, be better about adding midwifery and other types of providers? So are we going to create a more supportive postpartum care plan?
Are you asking also with those
Right.
midwives speak, from a legislative standpoint, because I know there are pilot programs that have been done in other states, and I've been looking at that too. Are you asking would they be compensated by health care? Because obviously that's the real issue, is how would they be paid? Other states are exploring that. Is that the question, is to see if the legislature would pass a law where they would be compensated from health insurance and perhaps Medicaid?
Is that your question, ma'am?
I think he's saying they're compensated now.
I can address that a little bit. Okay, so this is part of the big problem. The problem is not physician shortage. The problem is healthcare professional shortage. So yes, we don't have enough OBGYNs, but also we don't have enough midwives. And we have to have a better collaboration between obstetrician gynecologists and midwives. Certified midwives just as much as professional midwives. So this is, yes, your point is well taken, but it's a pendulum. We can't go from one end all the way to the other end. There has to be some sort of a happy medium in the middle where there's collaboration between physicians and midwives in order to get better care of patients.
I would only add that, I agree that it's an entire overhaul of the healthcare system that may result in more comprehensive care,
Great.
such as adding, different practitioners.
Great. We have time for a couple more questions. Let's go over here. Okay. So the question is, could community health workers be better utilized in our healthcare system in Texas?
I would say yes, particularly in terms of maybe home visits, which is actually the standard of care in many other countries, just not here. And that might be something a community health worker could do.
Yes, I think it's a great idea, but there's, again, bigger problems we have. Unfortunately, there's a lot of things that the state allow a community center to use or a federal qualified healthcare clinics be able to use or utilize or they get access or certain funding that private physicians are not allowed into. And that's another problem. Something like Title X, for instance, that the private physician cannot take care of patients with that particular funding, but you have to be a non-for-profit organization to be able to get into that. That cuts away a lot of patients. I know a lot of private physicians don't want to take care of patients with Medicaid or funding in that level, but those who do want to take care of these patients are not allowed, which doesn't make any sense. So yes, this would be a great idea. I think if we can, volunteers are there. There's a lot of people that can want to volunteer for the community, and this is one of the things that would be wonderful, that they'd just be able to sit down in the physician's office and call patients a week after delivery to make sure that they're not about to kill themselves. It's as simple as that. Are you doing okay? I'm not sleeping for the last 2 days. I feel like I don't like my baby anymore. I need somebody to call you back. Yes, we can utilize these words. Okay, now we do that. We find that patient, and she's at home, and I can't get her anywhere. What am I going to do? Call 911? What am I supposed to do? Mm-hmm. So it's a big problem, and it's multifaceted. And that's what I've been saying this all day, back and forth. Yes, there is little, and this part of the solution will help, but it's not enough. There's a lot more to that.
Mm-hmm. Real quick, I wanted to add on the 911 comment, and this is back to just the disparities in treatment. There are people, in minority communities and just colleagues and friends of mine who've said they feel more comfortable if they're feeling bad to call 911 versus just going into the ER, because they're so concerned that they're going to be ignored in the waiting room. So obviously if you come in the ambulance, you might get some treatment. And so I have a personal testimony. I took someone to the hospital the other day. A staffer of mine got really sick, and I noticed that while we were there was a lady there that was pregnant, and she'd come in because she had a really bad headache and her blood pressure was up. And she came in with orders from her doctor to be pre-admitted, an African-American woman. And she was still sitting there 2 hours later. And when she went in to hand the letter to the intake person, he immediately looked at it and said, there's no doctor with that name here. And it was a very common name. So there probably was not only just one, there probably were hundreds of doctors in that hospital with that name. And she sat and she waited, and I was looking like, oh, it's not really, should I get involved? And she kept hanging her head down, and she was with her mom, who was quite a bit older. And so I told her to go back up there, and I said, how long have you been here? And then I went up there, and I said, would you check her blood pressure again? She's been here for 2 hours. And I think it was 175 over 80-something when she got there. And so when he checked it again, it was 195 over 80-something, and he still told her to wait. And I said, well, what is the protocol? What would make you guys do something? And he said, well, it has to be at 200, which is really, she'd be having a stroke. And you know what I said, well, she could have a stroke. And he said to me, right then and there, he said, well, if she has a stroke, at least she's in the emergency room. And so, of course, needless to say, there's a whole backstory of what happened. Because how I was going to handle that and who he was speaking to. But we took care of it. Right, I got her seen and all of that. And I literally, had to go up and have a stranger be checked again. So can you just imagine? And so that's just that one guy. And maybe he's just that was just him. He's having a hard day. But something has to change in a cultural shift. We keep talking about that. And I'm sure the majority of the people that work at the hospital would have been mortified to hear him speak that way. But that happened to her, and he said it to me too. And maybe I wasn't dressed up. I wasn't wearing my state rep pin, or something. But I got it done. But this is what's happening in our country. And she could have died, or she could have had something happen to her that was irreversible, or lost her baby.
Okay, we are out of time. I'm sorry, I know. But thank you so much. Round of applause for our very esteemed panel. Thank you so much for coming. We will be up here if you really want to ask your question. And also, Texas Tribune is currently having their spring drive. We know this event was free, but to do our work, it ain't cheap, as our CEO has said. So you can donate through our hashtag at TTGive, and we would appreciate it. Thank you so much.